So welcome to this sign out with the professor. I have created 10 cases for us to discuss. Some are very simple and straightforward, and some are solvable, and some are still a puzzle. So that's kind of how life is in surgical pathology. Some things you can solve the same day, and some things it takes a little time to figure them out. I think the important thing for our discussion today is the process. The reason I think there's value in a live session like this is to see how other people approach the slide and what things that they have struggles with, you know. So if you see things that I do differently than you, then perhaps that will be helpful to compare and contrast. And if you see things that maybe I do wrong, you can send me a note or speak up. I don't want this to be just me talking for an hour, so please unmute yourself and ask a question if you would like to ask a question as we go along. And I will also try to pause to allow some time for questions to be brought up as we go through this. I have not yet mastered how to use polls in Zoom. So I won't have any opportunity yet for you to interact, but I'm hoping that as I continue to become more adept at this, that we can have a little bit of fun with seeing what other people think about the diagnosis as we go along. So again, welcome everyone, and I will try to be aware of when new people come into the waiting room. We'll begin with this first case that you see on your screen. As you can see, this is multiple fragments. This is a 35-year-old woman who had some abnormal uterine bleeding. And so that history, of course, makes you concerned about things like polyps or maybe hormonal dysfunction or possibly neoplasia. And so as we look at this, we don't really see anything that looks different one piece from another, except maybe this piece, which has, and this piece, which have some sort of bloody component to them. But the endometrium is often bloody, and so we'll come into higher magnification, and we can see that there is an array of glands. As we look at the stroma, we see there are some edematous areas and some more purple areas here. And the glands seem to have a contour of serrations or undulations in the epithelium. So they look to be fairly uniform in type. And just looking at this endometrium, I would say, you know, there looks like there's glandular secretion. This looks like a secretory pattern of endometrium. And we don't typically put a lot of emphasis on dating the endometrium beyond just proliferative versus secretory. But I think we could also perhaps go a little further, because this change in the stroma that we see here around these vessels right here, this is the beginnings of the formation of decidua, or what's called pre-decidua, where the stroma around the little spiral arterioles becomes a little bit more consolidated. The cells begin to look a little bit more like the cobblestone pattern cells of the decidua in a patient who is going to go on and become pregnant. So that stage, that happens actually about day 23 in the cycle, if you're thinking about a 25-day cycle. So it means we're getting towards the later phase of the full cyclic pattern of the endometrium. We'll look around at the other fragments here, and we don't see any other changes that look particularly worrisome. So we'll go to this area that looked a little bit different and see, is there some other explanation for her bleeding? And while we have some red cells in the stroma here, it doesn't look like we have a vascular anomaly or anything like that to explain her bleeding. We'll look at this other area over here as well. And I think it's going to be the same story. This is just artifactual bleeding related to the procedure. So it looks then as though we have a normal late secretory day 23 kind of pattern of endometrium. We don't see hyperplasia. We don't see any areas where the glands become abnormal. Now, this is an opportunity to discuss the criteria for hyperplasia or endometrial intraepithelial neoplasia, depending on which schema you're using. If you looked at an area like this, you might say, well, there are more glands here than stroma. And so therefore, this must be hyperplasia. But it's important to remember that the gland to stroma ratio is only one criterion for endometrial hyperplasia. And the other criterion includes a cytology or a cellular morphology that is different from the surrounding cellular appearance. And these cells here are exactly the same cells as you would have in other fragments away from that area where you have increased glands. So I would sign this case out as secretory phase, late secretory phase endometrium, day 23, 24. And then I would put the negative finding and say there is no evidence of hyperplasia or no evidence of neoplasia. Now I do that, I put that negative comment in my reports for a couple of reasons. One is because that's oftentimes the question that the clinician has when he has sent the case to us. Is this a neoplasia or a pre-neoplastic lesion? And so by being very explicit and saying that it is not there, I may save them having to track me down with a phone call or wonder if I considered that possibility. So that's what we have for that case. And I present this case not as a challenge, but as more of a how do you manage and report things of this sort. Now, the next case is a similar history. And this is a case that we reviewed with my resident a few days ago. And again, it's a patient who has abnormal bleeding. She's in her late 40s. And the resident looked at this and thought, gee, this looks like hyperplasia. And I think it's because she was looking at this fragment right here. And in fact, you look at this and you go, wow, look at all of these glands that are closely spaced. There's more than 50% glands compared to stroma. And I will grant you that the glands here are more closely spaced than normally you would like to see. But as we just illustrated, that's only one of the criteria. So as we look at the cytology for these glands, we should compare them with, say, glands in another area that are not as closely spaced. So let's go to another area and look right here and look at these glands. And here we see something that is a clue and a warning to us. So here the glands are sort of falling apart with a little bit of stroma around them, some blood, and a little bit of vessels here, and then little tiny bits of stroma sort of tied together in little knots and so forth. So I looked at this and I said, gee, this looks a lot like we have menstruation here occurring. Here's another area where we have the stroma here just sort of condensing and falling apart with blood in between. And this opens up one of my cardinal rules, I guess you would say, for evaluation of endometrium and the question of hyperplasia. And that is that you never make a diagnosis of hyperplasia in a menstrual pattern endometrium, where you have a lot of breakdown of the glands and the stroma. And here we can see we even have little thrombi in the vessels. Here, this hyalinized eosinophilic area. This is a vessel with thrombus in it. So this is definitely a menstrual pattern endometrium. We're past day 25, we're into 26 and so forth. But we have this one fragment here that was sort of lagging behind that looked a little bit more like hyperplasia here. And so that, I think, should save you a number of times from making the mistake that my resident, who was an experienced resident, was about to make in making a diagnosis of endometrial hyperplasia in a woman with a history that would be very compatible with that diagnosis and even a morphology with, sort of complicated, closely spaced glands. The diagnosis of hyperplasia is a tricky one, and this is one of the pitfalls that we encounter in a number of the patients who get referred to us, is that occasionally these menstrual patterns can be mistaken for hyperplasia. So those are two little vignettes and little insights into endometrial pathology. Any questions before we leave this topic and go on to the next case? Again, welcome to those of you who have joined us late or who are watching this later on video. I am recording this so that you can come back and refer to this, and the digital slides will be available to you, and hopefully without access problems. Okay, well, let's go on to the next case. Again, we're dealing with biopsy pathology. And this is a patient with who presented with a metastatic tumor of unknown primary. And of course, when we have that circumstance, clinically, they want to identify a primary because that can help guide the protocol that is going to be used. So this patient, and of course, they may do a number of possible things like PET scans and CT scans to identify possible primary sites. And this patient had that sort of a process and had multiple nodules, multiple areas where a PET scanning was positive. And they thought it might be a GI primary. So they did an upper endoscopy. And this is a biopsy from the duodenum. So in several of the fragments, we have fairly normal architecture, as you see here, normal pattern villi and muscularis and so forth. And I thought, well, we get so many normal duodenal biopsies, maybe this is just a normal duodenum and they were worried about sprue or something like that. We don't have that feature here, but then I began to look a little further and I came to this fragment here, and I began to notice some abnormality like this right here. And I think you can see that we have a change in the architecture of the cytology of this gland and this gland compared to these. So this looks like at least dysplasia or an adenoma, but it's actually fairly complicated and could represent potentially a carcinoma. So here you see this gland up close, and here we see a little bit more of this type of epithelium here. This began to be very worrisome that we have a primary carcinoma. So we looked at the rest of the fragments here, and sure enough, here we see more of this in this next fragment with a complex architecture. I apologize, this slide is pixelating so much. So here we have been able then, I think, to identify what looks like a primary adenocarcinoma that is arising in the duodenum. Now, of course, small bowel adenocarcinoma is rather uncommon, but may be a source for disseminated carcinoma of unknown primary, as it appeared to be in this case. Now, why is this not a more complicated lesion and ulcerated and so forth? Well, as you know, the duodenum, it is a difficult place to biopsy. And so this was clear down in the fourth portion of the duodenum, almost to the ligament of Treitz. And that's a difficult area for the endoscopist to reach and get a reliable biopsy. And of course, they may also be partially obstructing. But in this case, we were able to identify this adenocarcinoma arising in the duodenum. Now, of course, this looks like conventional adenocarcinomas of intestinal type and so forth. And we can see that in the small bowel, along with a few other types of adenocarcinoma. I've seen signet ring cell carcinomas in the duodenum, also presenting as primary disease and masquerading as other disorders like, Whipple's disease and so forth. So we made the diagnosis. My workup on this case included doing testing for mismatch repair proteins. While small bowel carcinomas are not highly associated with Lynch syndrome, the patient was somewhat on the younger side, and we did not think that was something we wanted to miss because of the implications for treatment with various options that they may have if that is present. So that was part of our workup. And I don't know further yet. We have not discussed this patient in tumor board. Here we can see also an area where we have invasive tumor in the submucosa, as you see here, muscularis mucosa and tumor deep to that. So we'll go on to the next case. Again, we're looking at bowel biopsies, multiple fragments. And usually when we get multiple fragments like this from a colonoscopy and so forth, it means that they didn't see anything that was a single lesion, and they're looking to exclude microscopic colitis or something similar to that. So we'll just sort of look through these fragments and see, is there anything focal that jumps out at us? At this magnification, you can just make out the architecture looks to be intact. It doesn't look like, Crohn's disease or inflammatory bowel disease. And usually they would be able to recognize that grossly. So most of the time, and especially in any patient who has diarrhea, the role of the pathologist in this situation is to identify things that can cause diarrhea. Now, as we come into higher magnification here, probably several of you have already seen the diagnosis here. At this magnification, you should be able to identify that there's a little accentuation along this subepithelial table. There's a little bit more pink tissue, a little bit of band of pink between the surface and the lamina propria. And we can see that in several of the fragments here. So here's another fragment that has this little accentuated pink area, and several of these fragments do. And that, of course, is very suggestive of so-called collagenous colitis. But to make that diagnosis, you need to have that thickening there, but you also need to be able to identify that you have damage to the surface epithelium in the form of either inflammatory cells, loss of mucin, and so forth. And in this particular case, it's not really highly prominent, that the degree of damage. But what do we mean by that? So let's just go into, let's take this piece here. And I guess we're kind of at maximal magnification. Let me shift this around. So in this situation, I think if we look at this patch of epithelium right here, we can see what I'm talking about. Many of these cells have lost their cytoplasmic mucin droplets. The nuclei are sort of scattered up and down, and it looks as though there are some extra nuclei here. Now, this was scanned at 20x rather than 40x, so I can't go even higher. But this would be the kind of feature that I would say is indicative of epithelial surface damage. And together with this band of fibrous tissue, would confirm the diagnosis of collagenous colitis in the appropriate setting. Now, of course, there are other things that might give you this sort of a change, maybe radiation or other kinds of things. But this is a patient, an elderly female who had diarrhea. And so this pattern of cellular changes is very, very consistent with that. My workup on this case included doing a trichrome stain, primarily to verify that this is collagen and not fibrin. But I guess I would say that I have yet to see cases where you actually had surface epithelial damage and this pink band of tissue where it turned out to be fibrin. So I think the morphology on H&E is quite satisfactory if you are very strict with your criteria to make this diagnosis without having to employ histochemical stains. Now, you can consider doing immunohistochemistry for, say, a T cell marker, a CD3 or something like that. And that will help to accentuate the fact that you may have increased T cells in the epithelial compartment, but it's not required. So that's the way I signed this case out was collagenous colitis. And I typically will put a note that sort of explains the findings and correlates with the presence of watery diarrhea. Most typically, these are elderly female patients, but sometimes you can see it in males and in other age groups as well. Commonly, the lamina propria also tends to be a little bit rich in inflammatory cells. So as you see here, there's not much variation in terms of the numbers of lymphocytes and plasma cells. But that finding alone is not sufficient to make the diagnosis of collagenous colitis. On the other hand, if you see surface epithelial damage without the collagen table being thickened, you can also make the diagnosis of so-called microscopic colitis. And that raises a slightly different differential consideration, which I think will be illustrated nicely with the next case. Oh, no, we have another case later on. Actually, let me go to that case now. We'll skip this one and come back to it. Okay, so we'll go to this case here. So this is a patient who has diarrhea and some cramping. And as you can see, it's kind of blue. There's a lot of blue cells here. But we don't see that accentuation of the collagen table in this case. We see the bluish, uniformly blue pattern in these biopsies. As we come into higher magnification here, I think we can begin to appreciate that there's certainly areas where the surface is damaged. Again, we can see we have loss of mucin here. We have areas that are sort of falling off, and maybe there's a little collagen here, but not really the same amount we were seeing before. We also can begin to appreciate that there's maybe a number of lymphocytes here in the epithelium, these little clear cells that stand out a little bit. And down in the crypts, these are a little bit more accentuated. So this, certainly with this damage, with the blue stroma, the lamina propria, the intraepithelial lymphocytes would be compatible with microscopic colitis. In other words, an inflammatory mucosal colitis that is not visible to the endoscopist. And that's kind of defines what they use that term to mean. So evidence of cellular damage. Now, that was, of course, helpful. It defines the cause of the diarrhea. It's this inflammatory process. But then the real interesting part of the history comes out. This is a patient who has a history of malignancy and has been treated with one of the new checkpoint inhibitors. So these monoclonal antibodies, either to CDK4 or to PD-L1, that are used as immunomodulatory treatments in patients who have the appropriate tumor type. Now, the problem with those is that they do have a fairly high frequency of gastrointestinal complications, and this is one of them. This is essentially what is now termed checkpoint inhibitor colitis, or CIC colitis. Immune checkpoint inhibitors, that's what, so it's IC colitis, ICI colitis. You can find it if you Google search it. Now, the findings with the colitis in those patients can be quite variable. They typically have symptoms of crampiness, diarrhea, maybe even blood in their stool. But the microscopic findings that correspond to that can be somewhat variable. This is kind of the beginning phase, maybe this microscopic colitis with the surface damage and so forth. As it progresses, if the drug is continued, they can actually get ulcerations, they can get crypt abscesses, things that begin to look more like ulcerative colitis or even Crohn's disease in some circumstances. So now we've just looked at one fragment here, but you can imagine that all of these fragments are really quite similar one to the other with this damage. And that, again, is a nice monitor that this is a diffuse change that is most likely related to the checkpoint inhibitor therapy. Typically, this will resolve as the checkpoint inhibitor is removed. They may, on occasion, require treatments with steroids or with other anti-inflammatory agents, sulfasalazines, and so forth, to help control the inflammatory process if they are hoping to continue the checkpoint inhibitor treatments. But this has been one of the limiting factors in patients being treated with that disorder. So I thought this was a nice contrast, comparing that to the collagenous colitis for you to look at. And you can come back and look at these slides at your leisure. All right, so let's take a look at another, this was the case to correspond to the duodenal adenocarcinoma case. This is a patient who had a mass in the head of the pancreas that appeared to be ulcerating into the duodenum. And so they came down and endoscopically and did a couple of needle core biopsies. I don't know if they're doing these in your institution, but in my institution, these are becoming kind of the method of choice to sample the pancreatic head and sometimes other areas of the pancreas. And the problem with that is that the endoscopically obtained needle core biopsies are very small. As you can see, we have lots of blood here, but we just have little tiny bits of tissue. These needle cores, just a few microns across. And so it can be very difficult to get much in the way of architecture. Now here what we see though is that we're seeing portions of muscular wall. So we're seeing stuff as it goes through the duodenal wall, and then we're seeing an altered stroma. And so that is, concerning. And here's maybe one epithelial group and another epithelial cell. So that's not really enough to make a diagnosis of cancer, at least in my book. But it can be very helpful to begin to know what to look for. And typically we will do several levels of these samples, and also save the tissue in between the levels so that if we need to come back for immunohistochemical studies, we can do that without having wasted this very precious tissue. So I'll come very quickly to the area that I have dotted as I looked at this the first time. And this I do on the slide to make it easier for teaching later on, but also for things like tumor board presentations and so forth. So here again, we see these organized smooth muscle bundles, and another area where we can see little clusters of cells that are infiltrating the desmoplastic stroma and looking very concerning for neoplasia. So this is an abnormal pattern and gives us an indication that not only is there a tumor in the head of the pancreas, but that it is invading the duodenal wall, and therefore potentially it's upstaged to a higher stage tumor. So amazingly here with perhaps 40 or 50 cells at the tops, we have provided a diagnosis, and we've also given them some staging information with this very, very minute fragment of tissue. This fragment and this one up here that I showed you initially were essentially the only fragments that had any sizable amounts of tumor in them. The rest of the fragments were just benign smooth muscle, as we look here. So this is where, in this situation, I don't want to be, how would I say this, overly aggressive beyond reason. And so I typically will show a sample like this to my colleague or colleagues, either via a consensus conference or just giving them the case to review. Sometimes we will review it digitally and to see if they can agree. Now, often in these biopsies, we will also get sort of free-floating fragments like these out here in the blood. And these can be of several types. So, for example, I think we've got cells here that have little mucin droplets in them. And these can be very difficult to distinguish from normal enteric epithelium because oftentimes pancreatic tumors are well differentiated. And so seeing a little bit of mucin in them could be tumor, could be still normal enterocytes. So I'm a little reluctant to make the diagnosis of cancer based on these kind of free-floating tissue fragments, unless there's really a high degree of atypia. Now, these fragments here, I think, begin to show much more hyperchromasia, pleomorphism, and crowding. So there probably is, these would also be carcinoma, but some of these fragments, you could make an argument to perhaps not call them as cancer because they might be enterocytes. So that kind of gives you some of the issues that come up with these very small needle biopsies. Additionally, with these kind of free-floating fragments, you can't be sure whether or not you're dealing with a cystic lesion, an in situ lesion, or whether you're dealing with an invasive carcinoma. So that's why it's helpful to see the tumor cells within the tissue or within the atypical stroma to confirm the diagnosis of invasion. These small tissue samples and so forth are becoming more and more of the issue in pathology. When I was training, you didn't have tiny biopsies like this. In fact, they were just barely inventing endoscopes. So the technology has advanced enormously since then. And that has created a whole new set of possibilities, but also a whole new set of challenges. So I'll just take a couple of questions going back here. MSI testing on the duodenal carcinoma was performed. We use the 4 mismatch repair proteins, MLH1, MSH2, MSH6, and PMS2 in our laboratory as our screen and report those findings as part of our routine reporting. And then a question here, could you talk more about the diagnosis of collagenous colitis? That diagnosis is really pretty much, as I indicated, based on finding surface epithelial damage and thickening of that collagen table beneath that surface epithelium. That surface thickening can be patchy, and that's why it's important to get biopsies from multiple areas of the colon, and they do a number of random biopsies. It can be progressive. It can be more severely developed in some areas and not in others. But in general, if you find it in 1 or 2 fragments in the sample that you're given, that's usually sufficient for establishing the diagnosis. Okay, we'll go back to the. Okay, so here's another case that maybe contrasts nicely with the duodenal case looking for unknown primary. This is a case where they thought the patient had a lung mass and a liver mass, and they thought that the liver mass here was going to be metastatic lung cancer, and so they sent it to us to document that and to obviously then to clarify the type of tumor that we were dealing with. So we can see here we've got normal liver on a couple of ends here, and then we've got a very blue tumor on the rest of the tissue here. So as we look at this, it looks to be mostly solid, has some stranding and intervening areas. We don't see gland formation. We don't see much necrosis. It seems to come and interface with the liver here in the sort of a sinusoidal pattern. You can see it extending out into the sinusoids of the liver. So it looks like a vascular spread, and it's nested in small nests. Looking at this at a little bit higher magnification, I think we can see very high NC ratio, and we can sense that there's a little bit of nuclear molding and variability there. And if we were able to go to a higher magnification, we'd see a high mitotic rate. We don't see a whole lot of karyorrhexis in this tumor. There's some little karyorectic debris fragments, but not much. So given the history of a lung mass, we considered that this could be a small cell carcinoma, a neuroendocrine carcinoma, or other possibilities, would be included in our differential considerations. So the next step, as I'm sure in most of your laboratories, would be what do we do in terms of immunohistochemistry to define this? So we were considering small cell carcinoma. We also considered a sort of small cell squamous cell carcinoma as a possibility. We considered, neuroendocrine, other types of solid tumors, possibly other locations and so forth. And so we proceeded with a panel that included things like TTF1, we included CK56, P40, and then neuroendocrine markers like CD56, phenoptophysin, chromogranin, and so forth. Unfortunately, after we had completed that panel, we only had positivity with a little bit of CK7 in some of the tumor cells, but no positivity with any of the neuroendocrine markers. No positivity with any of the squamous markers other than that CK7. So, and it was negative with TTF1, it was negative with CDX2. So what we were left with? Well, essentially at that point, because the case was compelling that this was a lung primary, we signed this out as undifferentiated carcinoma. So we did not call it small cell neuroendocrine carcinoma. We called it undifferentiated carcinoma. We believe it's probably metastatic from the lung. It probably is going to respond to treatment similar to a small cell carcinoma. But in that scenario, they might consider a couple of other options. They might consider doing more next generation sequencing to see if there were suitable targets, given that it's undifferentiated rather than a neuroendocrine small cell carcinoma. Those considerations would arise. So not every time that you have a metastasis can you really nail down a histologic type and origin. Here, the clinical story seemed to indicate that it was from the lung, and the morphology would be consistent with that, but it wasn't the morphology maybe that we expected in terms of the immunohistochemical profile that we were able to generate. So going on to one more case here, come back to this case. This is a case that came in consultation. The patient had presented with what appeared to be appendicitis, and on evaluation was found to have a tumor that involved the appendix and extended into the right ovary as well. So the lesion was excised, and as you might expect, there's and see here at low magnification, we have a little bit of epithelium here. We have a lot of very hyaline pink material. And then we got some sort of funny stuff over here, and so forth. But we don't see what looks like frank invasion. So we'll look and see this epithelial component here. It has a mucinous appearance. You can see a lot of clear mucinous type cytoplasm. There's a degree of architectural complexity here. The nuclei, however, remained basally located for the most part. There's no high-grade dysplasia appearing here. So this would fit from an epithelial standpoint into the low-grade appendiceal mucinous neoplasm. So then once you make that diagnosis, then the question becomes kind of staging. And obviously this lesion had involved the ovary, so that was a consideration here. But we also then look at the mucin here. So this can make a difference in terms of treatment. Here we see this predominantly acellular mucin, and what we're seeing here looked initially like these might just be sort of apoptotic cells or collagenous cells, or excuse me, calcified debris as cellular remnants, because they didn't really have the usual morphology of typical epithelial cells. You see they're kind of a different color, variable size, and so forth. So this is usually kind of a dystrophic calcification, single cell necrosis and calcification. Of interest, the referring laboratory who sent this case to us also did a cytokeratin stain, and many of these areas lighted up with cytokeratin. So even though there's not cellular architectural change in these areas, there still are cytokeratins present that are immunoreactive. And that's a potential pitfall because you don't want to call these non-viable cells invasive neoplasia. But the challenge was, of course, is that many of these areas are right out here near the serosa, which would change the staging if you classified this as epithelial cells reaching the serosa. That changes the T stage on these types of lesions. So that was kind of an interesting little pitfall, if you will, for this case, and a little bit of an unusual morphologic finding with these areas of seemingly acellular but keratin positive material. The other feature I think that, of course, is nice to highlight here again is how this epithelium that we see in these lesions often is just directly on this very hyalinized stroma. And this pattern of this type of epithelium, low-grade mucinous, this is lost a little bit of its mucin, sitting on this hyalinized stroma is almost pathognomonic for low-grade appendiceal mucinous neoplasms. And of course, the usual risk factors in terms of spread to the ovary and masquerading as potentially an ovarian primary comes in, and we've talked about that on other video presentations. Oh, so a question here from Dr. Ngun. The metastasis case is interesting. Could you do anything with that or wait for treatment response? As I said, I think the next most sensible step would be to look for targetable mutations or targetable pathways that the patient might be able to be a candidate for treatment with some of those more targeted therapies. And so in our laboratory, that would probably be the next step that clinically they would take, would be to look to see, is there a BRAF mutation? Is there a ROS1 mutation? Is there any of these other sorts of things in a lung cancer that we might look for to potentially identify a treatment? Because ideally, they'd like to find a treatment that would be that the tumor would be susceptible to. So that would be the approach with that case. Okay, so let me go back to my slides here. We're coming up to the last part of the hour. I think we've just got 2 cases left here. Let's go to this case here. This is just a fun little case of a polyp. And this was from the cecum. So we can see some normal mucosa here, a little lymphoid aggregate. And then we have this polyp here and a little bit more of it here. And I think even at this very low magnification, you can appreciate that there's a bit of villus architecture. So this has got villi forming here. And so, we might think, well, is it a villus adenoma or something else? And certainly that might be the direction to go. However, as we look at the epithelium, we see that it has more of a serrated pattern. It has this undulating pattern. And so if I take that combination of villus architecture and serrated surface epithelium, I begin to think of traditional serrated adenoma. But that is an unusual diagnosis to find in the cecum. That is an unusual lesion to find in the cecum. Typically, traditional serrated adenomas are left-sided. However, as I look at this microscopically, I can see these nice long villi. And if I look a little further, well, I think there's some areas here. Let me find them. One of the other hallmark features that we think of in terms of traditional serrated adenoma is the so-called ectopic crypts. And I think if we go into a location like this, we can begin to see that some of these areas, like right here, are what would, in some circles, be classified as ectopic crypts. It's not really dramatic. And of course, they're not totally specific for traditional serrated adenoma either, because they can be seen in a few other lesions. But some of these areas where it sort of begins to dive down and you get mucin in the cells begin to look a little bit like that. So I'm kind of faced with a dilemma here. Is this a exaggerated villus-like serrated adenoma, or is this a villus-like, or is this a traditional serrated adenoma with a relative paucity of the ectopic crypts? I think in either event, it doesn't particularly change the management of this case, but I thought it was an interesting differential consideration to look at how we would manage this. In terms of management, obviously removal is what's important, and then follow up afterwards to make sure that the patient doesn't have other lesions that develop. And since the timing for development of carcinoma from for traditional serrated adenoma can be shorter than say even a villus adenoma, the follow-up would need to be fairly frequent. Now, a question here from Ahum about pencillate cells in this polyp. So traditionally, these serrated lesions don't have the elongated pencillate nuclei. So these are almost all basally located, and they don't usually have that, that pattern of a conventional dysplasia, although we do see that on rare occasions. Okay, so we'll have one more case here, kind of a fun little case. Actually just recorded a specific video about this yesterday for later release, but this is a patient who's in his 30s and has a family history of granular cell tumors. And for some reason, and I don't know what prompted the initial discovery, he was found to have granular cell tumors in his colon. And so this is a repeat evaluation to look for more of these. And sure enough, here is a fragment of colonic mucosa. We did a sort of an endoscopic mucosal resection with the submucosa here. And we can see a submucosal lesion in this fragment, and then maybe a secondary lesion here at the other end. So two of them quite close together. So in the normal patient, if you just saw this coming across the routine bench, you might think of several types of lesions to be considered. But looking at this lesion at higher magnification, I think you'd all agree that these look like very nice granular cells, a little bit spindled, and have very characteristic granularity to the cytoplasm, some variability. Initially, these tumors were thought maybe to be of myogenic origin, but they've been long since discovered to be neural crest-derived tumors. They stain with S100. Now, there are other things that can occur in this location that also will stain with S100, one of which is the mucosal Schwann cell hamartoma, but that typically is in the mucosa, not in the submucosa. So that's a very important distinction to remember, that this lesion tends to be submucosal, whereas mucosal, by just as its name says, mucosal Schwann cell hamartoma is a mucosal disorder and presents in between the crypts. And I think even here we can see this is primarily submucosal. Well, those are the 10 cases we'd put out for discussion. And so we're nearly to the end of the hour. Does anyone have any other last questions you'd like to present or bring up? I really do appreciate you spending some time with me. It's my morning. I know for many of you it's the evening, maybe even late at night, and on a Friday night, you probably have lots of other things you'd rather do. So I'm very flattered and appreciate your time spent with me. As I have posted before, I will post the link to these slides so that if you want to come back and review them, if you want to take photographs, you'll be able to do that. If you want to share them with colleagues, you'll also be able to do that. And I'll also post a recording of our discussion today and presentation. I'm planning to do another one next month in July. So until then, thank you so much for joining with me.